Good evening, and welcome to the September webinar presented by the National Keratoconus Foundation, which is a program of the University of California, Irvine. My name is Jason Marsack, and I will serve as your moderator this evening. Tonight's topic is entitled The Genetics of Keratoconus, and will be presented by Drs. William Trattler and Dr. Elise Kramer. During this presentation, Drs. Trattler and Kramer will also discuss aspects related to co-management of patients. Both Drs. Trattler and Kramer will present their financial disclosures at the beginning of the webinar. Also with us tonight, Taylor Young from the National Keratoconus Foundation will be curating questions from the audience. So during tonight's program, if you have a question based on what you hear, you can type it into the question or chat box on the right part of your screen. We'll have some time during and at the end of the presentation to answer a few audience questions. Now, it is my pleasure to briefly introduce our two speakers. Dr. Elise Kramer is a residency-trained optometrist in Miami, Florida, who specializes in ocular surface disease and regular and specialty contact lens fitting. She graduated with a doctorate of optometry from the Université de Montréal. During her fourth year, she completed her internship in ocular disease at the Eye Centers of South Florida and went on to complete her residency at the Miami VA Medical Center. After her residency, Dr. Kramer became a fellow of the Scleral Lens Education Society and now serves as the Public Education Chair-elect for the SLS. Dr. Kramer enjoys lecturing all around the world in several different languages about ocular surface disease and specialty lenses. Dr. William Trattler graduated from Dartmouth College and continued his medical education at the University of Miami School of Medicine, with an ophthalmology residency at the University of Pennsylvania and a cornea fellowship at the University of Texas Southwestern Medical School. Dr. Trattler has many honors and accolades to his credit. Among them, he was an investigator in the FDA approval trial for epithelium-off corneal crosslinking. He is also an investigator related to epithelium-on crosslinking procedures. Dr. Trattler currently serves as Director of Cornea at the Center for Excellence in Eyecare. Tonight, Dr. Trattler will begin our presentation. Dr. Trattler.
Jason, thank you so much. And just to share our relevant disclosures for myself, it's Avellino Labs, Avedro/Glaukos, CXLO, and Oculus. And Dr. Kramer?
My relevant disclosures are Contimac, Spectrum International, and Visionary Optics.
Well, I know we're both very honored to be here, and we just both love, caring for patients that have keratoconus because we know we can both help so much. Dr. Kramer's been, her whole career has been really focused on helping patients with keratoconus. And these are some of the pearls and a little overview of the talk. First, the most important thing to understand is that keratoconus is progressive. Sometimes it goes fast, sometimes it's slow, but it typically is progressive. And what Dr. Kramer and I have both learned is that it's much more common than was once thought. It can run in families, which supports the roles of genetics, but the majority of cases of our patients that we see don't have family members with keratoconus. We know that crosslinking is an effective procedure for stopping progression of keratoconus. And lastly, and most importantly, scleral lenses have just been a game-changing technology for our patients with keratoconus. It can really change the day because patients who have lost vision and can't see well can all of a sudden see beautifully with scleral lenses. I'm a huge fan. I think it's changed so much for my patients, and I'm so excited to have experts like Dr. Kramer available to help.
Yeah, and it's really great that, I think the best combination is having that cross-linking and scleral together. I think is the best, for the patients.
Absolutely, because they both hit on different parts of treating the condition. So many of you out there may have keratoconus. I assume that's why you're here. So I'm just gonna give a quick overview of topography. That's a test that Dr. Kramer and I and all your eye specialists do to measure the shape of the cornea. And there's all different patterns that can occur. So maybe you can see if any of these match your own eyes. But like this is the first picture is that of keratoconus, where there's a red area, which is the seat part, and a flat area, which is blue. The second image is what we call a crab claw pattern, where the red is looks circles around a little bit, but then it's flat above, and that's called pellucid pattern keratoconus. And the last image is that of occlusive marginal degeneration, which is where, again, this kind of looks like a lobster claw or a crab claw, but the thinning is very down towards the bottom of the cornea. Now, when we're looking at topography, what Dr. Kramer and I do is we look at not only the image and the colors, but we look at the scale. So when we see this patient on this image of the topography, you see there's a red area and a blue area with some numbers, but we can also look to the left and see this scale that tells us what the colors mean. Lower numbers are flatter, and steeper numbers are typically in red. And I'm just going to share one patient. This is a patient that I took care of where when they first came in, they had very little keratoconus. You can see there's a little spot of yellow, and there's very mild difference between the top and the bottom of the cornea. And then the patient came back 2 years later and had progressed, and now you can see there's much more of a difference between the top and the bottom. The top part flattened, and the bottom part got steeper. And so that's what we typically see in keratoconus. It's a shape change of the cornea where you're getting a steepening of the cornea in one area, but you actually get a corresponding flat area in a different area. And you can see when you look at a comparison map called a difference map, what the blue areas are what got flatter, and the yellow and orange areas got steeper. So you can see what happened. This is a comparison from the first exam to the second exam and the change that occurred. Flatter and steeper. Dr. Kramer?
Yeah, so it's a huge honor to be here. Thanks again for having us. And like Dr. Trattler said, keratoconus is really something that we both are very passionate about working with and that we see on a regular basis. But how common is keratoconus? And classically referenced, we know it's about 1 in 2,000. But this is based on a study that was done a really long time ago. And we know that they used retinoscopy and scissor reflex and also keratometry outcomes to come up with this diagnosis. So we know that today we have way more precise methods of diagnosing keratoconus, and we still don't have the same, studies that show this number. So this, again, was a very old study with older kind of methods of diagnosis. And then there was a study in the Netherlands that was on 4.4 million patients from a mandatory health insurance hospital database. And there, the prevalence of keratoconus was 1 in 375, so a lot more than 1 in 2,000. And what was the average age of diagnosis? And was it more common in males or females? On this study, the mean age of diagnosis was about 28.3, and 60.6% of the diagnosed patients were male. So according to this study, more common in males.
Yes. So one thing that always is interesting is Dr. Kramer and I both see patients, and we know that if we can identify patients early, we can often diagnose them when they're in their teens.
Yeah.
But what this tells us that these patients are often not identified until much later in life. They probably have had it for many years but never realized it. And that's why the average age is 28 when it should be closer to like 18 or 19.
Yeah, 28 years old is considered relatively late to be diagnosed with keratoconus, since we know that most of the time it appears a lot earlier than that.
Absolutely. Oh, I'll share this one. So I was curious on my cataract patients, how many patients had keratoconus and patients coming in for cataract surgery, because we perform a topography on every patient. We looked at 400 eyes of patients, so 200 patients, 400 eyes. And found out that 3% of our patients had keratoconus, and then 1.4% had a pellucid pattern. So it's really 4% of our patients. These are all patients between 60 and 85 years of age had keratoconus. So many of these patients had no idea they had keratoconus. They thought they weren't seeing well because of their cataracts, and we're the ones who made the diagnosis. And likely they could have made the diagnosis many years earlier if they had only had testing. Dr. Kramer?
Yeah, so there are other studies going on right now. Obviously, we're trying to figure out what is the real prevalence of this disease, and we know that it can be above 2%. And several studies have shown that several countries, we have here in red in this table showing that in India, Israel, Iran, and Saudi Arabia, it was over 2% of prevalence in those countries. So, oh, sorry, go ahead.
Go ahead. I think it's a helpful slide.
So I was just going to say that how do we, obviously it's easier to diagnose keratoconus when patients have symptoms, but at the beginning, they may not have any symptoms. And if you suspect it, I mean, obviously, you know, when we refract, we do retinoscopy, so that's something that we can use as kind of a screening tool. But if you really have a doubt, topography definitely is the way to go. But if people have mild to moderate symptoms, what they'll experience is like ghosting or blurred vision, even with glasses. So even with the best prescription you can give them in glasses, they'll still feel like the vision is not quite sharp. And obviously in more severe cases of keratoconus, they'll have significant blurring of vision where glasses are just really not helpful, and they don't really notice. Sometimes they don't even notice a difference if they're wearing the glasses or not.
Yes, and these are the patients with severe that can really benefit from scleral lenses because you can restore their vision back to a normal level.
Absolutely. So if you see that apple just showing what a ghost image is, so it's not necessarily double, it's kind of just like a little, it's like they see two letters, one in front and one in the back, and you can see there the arrow at the bottom. So it's really, really cumbersome. It really bothers a lot of patients because they know what clear vision is, because again, as Dr. Trattler mentioned, it is progressive. So they've had clear vision before, and then they're looking for that sharpness, which they just can't get anymore.
So one of the other challenges, as Dr. Kramer was pointing out, is patients have symptoms, but sometimes patients don't have symptoms. And so, and that's why I think, and that's why we both realize that keratoconus is often discovered late. In other words, if everybody got topography on their eyes at age 18, we probably would pick up keratoconus all the time, but we don't. It's not a routine test. And here's just some interesting patients. You see, these are all patients that have keratoconus, and the question is, what was these patients' vision? So everybody who I've shown this picture to said that all four of these patients have a good amount of keratoconus. The question is, what were the patients' vision without glasses, just in the real world? And it turned out that all four of these eyes could see 20/20 without glasses. And it's because the location of the cone was just a little bit inferior. The cornea was bulging outwards, but not in the center. So it wasn't affecting their vision to a degree that it was bothering them. And that's why, the patients are often able to continue to work and do all their normal activities, not realizing they have this condition that's getting worse and worse.
That's so interesting. And a lot of these patients actually, when you ask them, like it's like you have to probe them, say, well, what about when you drive at night? Do you see any halos? And then they'll be like, yeah, once in a while, but it's like they think nothing of it or it's something that they choose to live with because they think it's normal.
Exactly, especially with the other eye. This is one eye, maybe the other eye's seeing better and less advanced, so they're getting by. But you're right, they'll see the nighttime issues. That's a great question. And also they may notice ghosting as well.
Yeah.
Now, one interesting situation is when we have patients coming in for LASIK and cataract consults, it's really interesting that we'll see these patients come in and they think they're not seeing well, and they think that LASIK is going to solve the problem or cataracts are going to solve the problem. And then we do the topography and we identify they actually have a good amount of keratoconus. And these are two patients that came to see me on the same day for LASIK consultations, not realizing they both had keratoconus. They were unrelated and were sent by, and they came in for different reasons. But they somehow came in to see me the same day. They both had a good amount of keratoconus. If only they had, and here's my question to them: if only one of the doctors previously had done a screening test like a topography, we could have picked this up earlier. So I'm hoping that over time we'll start to institute topography as a routine test in eye exams. It's not there yet, but I think it will be at some point. So Dr. Kramer?
Yeah, and it's really interesting that you're talking about LASIK because these patients that are going in for LASIK is probably because they're not comfortable in contact lenses, in regular contact lenses, and they can't see that well in glasses. So maybe they're thinking, oh, well, I'll just get surgery, but they don't realize it's because they have keratoconus. And so the incidence of patients that actually have keratoconus but that are discovered on a LASIK consult is pretty high. If you look at this study, the incidence of keratoconus in Saudi Arabian or refractive surgery prospects was 18.7%. And keratoconus was the most common reason for not performing refractive surgery and accounted for 24% of the cases. So again, a lot of these patients are going in for surgery because they're not tolerating their contacts or their glasses, so they're trying to find an alternative, not knowing that they have keratoconus.
Absolutely, yeah. So it's just a crazy high amount in that study. Now, what about in kids, Dr. Kramer?
So this was a really good study, prospective, cross-sectional, observational, multi-center study, in which they collected data from pediatric patients from 6 to 21 years of age using Scheimpflug corneal topography, and the average age was about 16.8, standard deviation of 4.2, and here we see that the prevalence of keratoconus was 5.56% for one of the examiners and 3.83% for the other examiners. So the final keratoconus prevalence here was 4.79%, which is 1 in 21 patients. That's really high, and that's of course in the pediatric population. But it's just showing that, you know, there's so many different studies showing different numbers, and really most likely the number is going to be a lot higher than 1 in 2,000.
No question, absolutely. And so, you know, in that study that you just shared with us, they identified all these kids with keratoconus, and this is a study that you may want to share your thoughts on as well.
Yeah, and I think one of the most important things to understand about keratoconus is the nature of the condition is that it's going to get worse. We know that keratoconus is going to progress, and sometimes patients don't realize, and you tell them, well, didn't you see better 5 years ago and then 5 years before that, and then they start to realize, yeah, my vision has been getting worse. And it's not the same as just changing your glasses every year in patients without keratoconus. It really does progress, and progression can be pretty severe. So in this specific study, we see that 52 out of the 59 eyes, so that's 88%, progressed over 1 year. So that's really, really significant. And we just have to categorize this condition as a progressive condition.
No question. I mean, it's impossible to predict which eyes won't progress. And if they progress, that means the cornea is getting steeper, and they may be losing vision. So the sooner patients can be identified and treated, the better, typically.
Yeah, and sometimes I see patients that think, oh, I only have one eye with keratoconus, but we know it's bilateral. It's definitely asymmetric in a lot of cases, but we know it's bilateral. So if both eyes can progress, it's not just one.
Absolutely.
So that brings us to the genetics of keratoconus, which is of course the topic of this webinar. And we know that no single gene has been identified as a direct cause of keratoconus. Many genes have been identified, which increase the chance that a patient will have keratoconus. And so these are called susceptibility genes. We know that there's 200 polymorphisms and more than 50 genes or loci. So there's a lot of different genes that can make someone more at risk of developing keratoconus.
Absolutely. And that may be why we see differences in the prevalence in certain countries. Like in some countries, when we saw the data, it may be higher than in other countries. Some ethnicities may be higher. We don't know the answer yet, but it's just something to consider. We know that there's some type of underlying genetic cause, but it's still a lot of work to be done.
Absolutely.
So I'm going to share a patient of mine that came in. She's a super nice patient of mine that was diagnosed with keratoconus in her right eye, and she underwent crosslinking in February of 2020, and she had a question: should I worry about my 8-year-old son? And this is her topography. As you see, the right eye has obvious keratoconus. The left eye is a little suspicious for keratoconus, but at this point, she did not need crosslinking. We could observe her. So again, she had successful crosslinking, did beautifully in the right eye. Again, flatter and steeper. This is the Preop Image. So she brought in her 8-year-old son, and the patient and her son saw great 20/20 vision with glasses. And these are the maps. And as experienced experts at interpreting topography, both Dr. Kramer and I would say there's some suspicious findings to this topography, in that the axis, which is kind of that red line, is not quite straight. There's a little, we call it a little skew, a little curve to it. It's a little bit more obvious to see in the left eye where it doesn't go, the yellow doesn't go straight, it kind of curves off to the right. But this isn't quite enough to diagnose as keratoconus. It's just someone who's suspicious for keratoconus, and obviously has a mom who has keratoconus. We did some other parts of the test looking at things like Kmax, which is the seamless part of the cornea, and other findings, and the corneal thickness was in the normal range, so suspicious but not keratoconus. So the question was to crosslink now or observe, and my recommendation is just to observe. I did not think that that even though there's a high risk of progression, I at this point I did not see that there was actual keratoconus. Just I recommended observation and come back in 4 to 6 months. But then there was a question, you know, how quickly does this progress? And again, I said 4 to 6 months. I wouldn't wait a year with a family history. So that was our discussion. And then we just talked about genetic testing and whether that might let us better understand whether her son might develop keratoconus. Perhaps there is, her son has some type of genetic risk factor that means that the chance of him developing keratoconus will be even higher. Basically, there's a new test. Dr. Kramer, do you want to share a little bit about the test?
Yeah, and that's such an interesting case because you want to know if someone's at risk, and of course you have the parent that has keratoconus and the topography looks a little suspicious, but it would be so great to have something else that could give you a hint as to whether this was going to be keratoconus or not. And so this genetic testing is available from Avellino. And so they test over 1,000 variants across 75 genes associated with keratoconus. And they use an integrative weight scoring model, which was developed for this. And obviously the goal is to calculate the risk score. So it's going to tell you approximately, you know, what is your risk or genetic risk of developing keratoconus. And so the patient cohort consists of 547 keratoconus cases and 274 controls. And so we can see basically based on these results, we have this scale at the bottom where you can be categorized as medium risk, low risk, high risk, depending on the score. So it's a test that shows you a score and which will tell you basically how at risk you are of developing keratoconus.
Absolutely. So, and I guess the thing to point out is if you're at high risk, it doesn't mean you're 100% going to develop it, but your risk is very high for developing it. And someone with a low risk could still develop it as well, because these are really helpful, all the genes that have been identified, but there still may be some other genes that have yet to be identified. It's just but this is a very promising technology.
It's a useful tool to aid you in deciding how at risk one of your patients is of developing keratoconus.
Absolutely. And one of the ideas would also be to consider for patients that are going to have LASIK surgery, maybe someone who's in their 18 or 20, to make sure that they don't have any genes that would put them at high risk for keratoconus, because we typically try to avoid LASIK in patients that have actual keratoconus. So this is just the findings, and basically the key thing here was that they found a couple of genes that were low risk and medium risk, and so the overall risk was, you know, between low and medium. Again, this is based on the initial evaluation of 547 keratoconus cases and 274 controls. So the key thing is that without the genetic testing, my recommendation was to wait 4 to 6 months. With the genetic testing, I still felt about the same. I felt that with the medium risk score, I think that the chance of this patient needing crosslinking in the future is high. But I want to at least have them have some degree of actual keratoconus before we do the treatments. So that's kind of the game plan overall.
But if someone has a medium risk, you might want to follow them a bit closer. Like one of the questions you asked was, how do we know when to follow this patient up? And this test could provide you with a clue as to how closely you want to monitor for progression.
Right. So a perfect example would be if for some reason there was no family history, like I didn't know the mom already had keratoconus, and I saw these scans, I may say, oh, come back in 9 months or a year. I'd be less worried. I'm more worried because I know the mom has it. So if there's no mom or no family member and we got the genetic testing, then I would say, okay, come back sooner. I'd be more worried versus they were all negative, then I'd say, oh, we have time.
Exactly.
Beautiful. So that's kind of a little overview of the genetics part. We're ready for some questions, Jason.
Yeah, great. Yeah, sure. Very nice. Thank you for that. So far, you know, this kind of idea of the test you're talking about here as an additional, you know, tool in the tool bag of understanding kind of what's going on with the patient is really interesting. I was curious if you've had any like long-term follow-up with that testing to see if the predictions are actually if some of those predictions are actually being borne out, or is the technology still too kind of new to really know, or kind of where are we with that?
Yeah, so they really just got released in the last 9 months, so we don't have long-term follow-up yet. And then COVID hit, and that kind of threw a little wrench in everything as well. So this is definitely a really promising tool and technology, but we'll probably need another 1 to 3 years and more patients tested to get a better sense.
Sure. Yeah. Okay. A couple of questions coming through. I really, really interesting information about the kind of how common the disease is. I think one of the things that patients often express is that keratoconus can feel like an isolating disease in some cases because, individuals with keratoconus may not know another individual with keratoconus. They may feel as if they might be alone, but it sounds like what you're saying is that, this disease is actually much more common than we ever maybe imagined.
No question.
Yeah, it's extremely common.
Yes, I mean, it's surprising how many people who I'm friends with who either they have it or their family members have it. And it's been, just unbelievable how many people that these just aren't a few random patients that come to see me. A lot of times it's personal, where I'd actually known people for years. All of a sudden we find out that their child has it, or I have colleagues. It's just surprising how many people actually have this.
Yeah.
We have a couple of questions about, what are some common visual side effects of having keratoconus? Halos, maybe shadows. Individuals that may wear scleral lenses and they still have some shadow. I mean, are these kind of typical outcomes from the disease that the two of you are seeing?
So I'll start. So everyone's different. I mean, everyone has different symptoms because it depends how it affects each person. Again, some people are asymptomatic, and some people will have ghosting, as we showed you, and some people will have blurry vision. And as you mentioned, Jason, a lot of people see blurry even, or feel like they see shadows even with their scleral lenses. And a lot of the time, these patients have higher order aberrations that maybe the scleral lens they're wearing is not correcting for. And a lot of patients with keratoconus have aberrations like what's called coma, and that can cause some shadows even with scleral lenses on. So that I know that can be frustrating, but those are certainly things that we see in patients with keratoconus. What do you think, Dr. Trattler?
No, I agree. You nailed it. I agree 100%.
Yeah, that was one thing you mentioned, was that you do see individuals who have presenting with keratoconus but are still seeing 20/20. But you also mentioned that some individuals, we kind of only know our own visual experience, if you will. So we kind of get used to some degree what our visual kind of perception. So we may tolerate those to some degree, but maybe as they become more impactful on us, maybe then is that when you kind of start to see people presenting and maybe wanting some of the more advanced solutions?
Right. I think that patients don't realize they have it. So it goes in two ways. Like patients aren't going to come in saying they have keratoconus. They're going to come in with complaints that will prompt a doctor to perform testing, including topography. But I mean, sometimes you'll see patients that they're not seeing well, they have lost their vision, and they're going to they get all these other tests, and the doctor never performs topography. It can take a little while to get diagnosed. So I think the key is that I think eye doctors just need to be more aware that this is a very common condition and should screen for it more commonly.
Yeah, do you, it sounds like you both have experience with either Dr. Trattler being involved in some of the trials and maybe Dr. Kramer with co-managing some individuals with cross-linking. Do you see kind of is there an age associated with when individuals would have that, or is it more of a severity, or how do you determine who's a good candidate for that procedure?
So we're going to talk about cross-linking in just a little bit.
Very
We're
good.
going to hit the age and stuff. So
Also,
yeah.
sorry, I want to make a comment about how you were saying, you were talking about vision. And I think what's important also is everyone has different visual demands, right? So some people are seeing 20/20, but they need vision, because they are of a specific job or because they play a specific sport. And so they need to be like 20/15, let's say, or they want to be 20/15, but whereas some people see 20/40 and they're perfectly happy. So everyone's different, and obviously we need to respect, everyone's visual demands, and that will also determine how symptomatic they are.
Great comments, yes.
Maybe one last, because this one will deal with, this question comes from the chat and it kind of deals with the genetic aspect, because I think we'll be maybe leaving that section here, and it has to do with the potential impact on insurance. If an individual might be considered to have a pre-existing condition, or if they do undergo the genetic testing.
Yeah, that's a great question. That's definitely there's a lot of genetic testing going on, and there's a lot of work being done in that area. I just don't know what, since I guess there's only, I really don't know. There's not like a straightforward gene that if you have the gene, you have this condition. It just means there's a slightly higher risk. And thankfully, there's also a great treatment for this, both the scleral lenses and cross-linking. So, it's not like someone's going to require surgery typically, with this condition, especially if you're caught early. So, thankfully, I don't think that would really apply too much, but that's an area that I'm not an expert on.
And again, it's what it is this genetic testing is just an additional tool to help us know how closely we have to monitor someone, and to see if they develop keratoconus.
Okay, why don't we, we'll go ahead, we have a couple more questions, but just, I'm gonna keep kind of trying to organize them a little and go ahead and continue with the presentation.
So Dr. Trattler mentioned that it's really important to diagnose this early because as he mentioned, it is, and we commented on the fact that this is a very progressive condition and we know it's going to get worse. So the earlier we catch it, the earlier we can correct it, and of course, the earlier we can prevent it from getting worse.
Absolutely. So Dr. Kramer, what's your advice for a parent who has keratoconus? When should they have their child checked for keratoconus?
I mean, upon whenever they can bring them in. I saw, I think, a patient last month that I was fitting her with scleral lenses for keratoconus, and she brought her daughter in the office for just a comprehensive exam, and her daughter had some astigmatism. Obviously this is anecdotal, but what I'm saying is the daughter ended up having keratoconus, and I just think it's so important to do topography, as you mentioned, on everyone, but especially on children of those with keratoconus as soon as you can. I mean, as soon as you diagnose a patient with keratoconus, tell them to bring their kids in.
Absolutely, I agree. So let me share. There's a couple of cases. These are some patients that came in with keratoconus, and then they were planning to have the cross-linking procedure, but some of them weren't able to get it right away. So here's a 10-year-old, and this just shows how quickly things can change. This 10-year-old male, a high risk for progression because they have a good amount of keratoconus already. They came back just 3 months later, and we look at this value called K max, which is the K stands for keratometry, and that's basically the steepest part of the cornea. And imagine that 43 to 44 is average and normal, and 48 to 50 is kind of the cusp. 58 is pretty high. It can go up to over 100 actually, but those are really, really, really advanced. But you can see he went from 58.7 to 63 in just 3 months. And then when we look at the difference map, what it shows us is that not only did the steep part get steeper, but the flat part got flatter. So there's just more asymmetry, and he had significant drop in vision in just 3 months. So that's why we're trying to be on patients that or discuss with patients who are diagnosed. The sooner we can get them treated with cross-linking and intrascleral lenses, if that would help them, they'll get them patients seeing better and preventing them from getting worse. Here's a 14-year-old female that progressed over 18 months. You can see that they started off in May 2014 and they came back in November 2015, 18 months later, and it's significant progression. Again, you see the small amount of red in the first scan, and now it's much more in the second. And the K-max went from 53 to 63. The cornea got thinner. Again, looking at the difference map, you can see again, the top part got flatter, the bottom part got steeper, so it really reshaped over time. Here we have another patient. Now we're talking about age. Jason asked about age. Here's a 48-year-old female with central keratoconus. And then the patient came back. So the first one's in the middle, the second one's off to her left. You can see there's much more red, and the difference map shows that the central area got much steeper. And so again, and the K-max went from 55 to 58. So just because you're 48 or 50 doesn't mean you can't progress. And we see a lot of patients progress who are older. It's kind of a myth that I know Dr. Kramer has heard as well, that once you're a certain age, I've heard as young as 35, you won't progress, and that's just not the case. If you do actually follow people closely. Here's a patient that can kind of break that myth as well. Here's a 70-year-old patient with a cataract, not aware of keratoconus when the patient came in 2011, had cataract surgery in 2011, and came back in 2016 with an increase of the K-max from 45 to 54 to 56. And this one zone got steeper by about 2.2. So you can see, again, this patient was born in the 40s, so an older patient. They came back in 2016, and they came back 2 years after that, and they had further progression, another 2.1 diopters of steeping that area. And it was at this point that they had cross-linking. Now, in the late 70s, and patients at this age do really well with cross-linking. So thankfully, we identified the progression and were able to treat the progression to prevent further worsening. Here's another patient that we watched carefully, are patients that have had LASIK that are getting some weakening of their cornea. The patient's right eye already had keratoconus that had developed after LASIK, and left eye came in with that looked pretty normal, but there's a little suspicious area at the bottom, which I'll show you a little bit more in the next slide. So if you look right there, there's that little area in the green was a little suspicious, but some patients without keratoconus can have that as well. But we obviously were watching this patient. The right eye had already undergone cross-linking, and we watched the right eye for 5 years. And now, after 5 years, and the patient was seeing 20/20 without glasses to begin with. You can see they're just starting to get a little bit of worsening of their vision, not a lot, but you see this worsening area of steepening. And the difference map shows again that significant steepening in one area and flattening in the other. And so this is an important sign that tells us that this eye needs cross-linking as well to prevent further progression. It's just an overview that, cross-linking thankfully is FDA approved now for both keratoconus and ectasia after LASIK, or keratoconus after LASIK. There's also a condition called occlusive marginal degeneration, which is, I showed you the image in the very beginning, and that condition is considered off-label, but cross-linking works very well for that as well. The purpose of cross-linking is twofold. Number one is to stop progression. It's very, very effective at preventing the keratoconus from getting worse. It's 99% successful that one treatment will stop progression. But then we also expect to see these findings: improvement in corneal shape, and often see improvement in uncorrected vision and improvement in their best corrected vision. That means with glasses, that over years, over months and years, we can see the shape of the cornea improve. And that if it improves, we see improvement in their vision, often either uncorrected, best corrected vision, or both. As far as when to consider cross-linking, literally all patients with keratoconus can benefit, or with these conditions can benefit. So keratoconus, occlusive marginal degeneration, and post-LASIK ectasia. And then progression of keratoconus can also occur very rapidly, as we showed earlier, and can occur at any age. And so the interventions, the goal is to really stop progression of keratoconus. And the things that we recommend, and Dr. Kramer may want to mention this, is eye rubbing. I know, any thoughts on eye rubbing?
Oh my God, all the time. And eye rubbing is definitely something that can cause progression, and we have a lot of evidence for that.
Yeah, so definitely try to advise our patients to stop eye rubbing. If they undergo cross-linking but they keep rubbing their eyes, they can actually break through and may need a second treatment. We have a number of techniques that have been developed with cross-linking. You can do epi-off with a manual epithelial removal. There's also a way of doing the epi-off where you actually use the laser, like we do with laser vision correction, to take off the outer layer of the epithelium that way with epithelial removal. And then there's a current FDA clinical trial by Avedro on epithelial on cross-linking, and we're hoping in the not too distant future that we'll get that technology FDA approved. Avedro now it's a company called Glaukos to actually purchase Avedro. So Glaukos is working very hard on a clinical trial, which has completed enrollment, and then hopefully we'll get an FDA-approved version of epithelial on cross-linking in the not too distant future. Other treatments include Intacs, which I personally am not a fan of, but some of my colleagues do really feel that Intacs can be helpful. And then one thing we try to avoid at all costs is corneal transplants. Corneal transplants, in my opinion, should be reserved only when there's severe scarring so that patients can't see with a scleral contact lens. If patients can see with a scleral contact lens, there's no reason to do transplant because typically, not always, but typically because the scleral lenses can give just dramatically improved vision. And that, I don't know if you want to comment on I know you're talking more about scleral lenses, but in my experience,
one thing I want to clarify here is that scleral lenses do make vision better, but they do not stop the progression of keratoconus. So I think that combination is key. You know, cross-linking to stop progression and scleral lenses to improve vision. But again, scleral lenses do not stop the progression of keratoconus.
Absolutely. Thank you for sharing that. That's an excellent point. They work together. So these are just thoughts. Our goals for keratoconus is to identify it as early as possible. Children and young adults are at high risk for progression. Patients of any age can undergo cross-linking. And my experience with treated patients, as young as 5, but once kids are 7 or older, they can do very well with cross-linking. It's a very easy procedure for them. The key, of course, is educating the family members and the patient to stop rubbing their eyes. And we often will treat, if they're rubbing their eyes because of itching or allergies or dry eye, we treat that, and that often would be helpful. But the key is to avoid eye rubbing. So here's an interesting patient. Just sharing, I think, 1 or 2 patients here. There's a 33-year-old male that, and the question is whether this patient has keratoconus. And I showed you pictures of keratoconus before where there was asymmetry, where there was a steep area, a red area. And so there's a patient who came in February of 2020, and you can see that the yellow area is quite symmetrical. It's vertical. It's not like we use the word skew, but it's not curved. And it looks pretty symmetrical. The corneal thickness is a little bit thin, but overall this looks like pretty normal. And I showed this to colleagues, and most people would call this a normal corneal shape overall. And so what I want to share is that this patient actually started off with keratoconus. This is their map from April of 2017. They underwent cross-linking in 2017, and they came back in 2020. So about 3 years later, and now they had this reshaping occur. And now their cornea looks much more normal. So cross-linking can help improve the shape of the cornea. Obviously, they're seeing better as well because the shape of the cornea is better. This is the difference map showing where the flat area superiorly on the top part got steeper. It's more yellow. And if you see the difference map, the blue and purple area is where it got flatter. So over these 3 years, there's significant change in the shape of the cornea, so it normalized. And these are some of the, we don't always get this degree of improvement, but that's our hope with cross-linking, is not just to stop this condition from getting worse, but to hopefully see improvements in the corneal shape over time.
Wow, that's
amazing. And there's just another page. What's that?
I said that's amazing.
Yeah, the number of patients that that actually look normal that I'm putting together for to kind of publish, to put together, because it's always wonderful to see the nice improvements for these patients. So here's another patient that I just kind of mapped out their Kmax. Remember, Kmax is the steepest part of the cornea, and this is just to give you a sense of what happens over time. Is it's not immediate. I typically tell my patients after crossing to come back and see me in about 6 months, and after that we see patients once a year. And so there's a patient that had their treatment in February of 2014. They came back in May of 2015. Their Kmax had dropped to 53. But you can see that that's just the beginning. They come back, you know, in May of 2016, now it's 52.3. They come back in February of 2017, it's dropped to 50.5. They came back in February of 2019, now their Kmax is 49.8. During this whole time, their cornea is reshaping, their vision slowly getting better. So the one single treatment of cross-linking leads to this continued change and improvement in the shape of the eye over time. So it's pretty exciting. I get excited when I see patients coming back 5 years, 7 years, 10 years later after cross-linking, and we see the improvements over time. So this patient got six hours of flattening over 5 years. Again, it's not immediate, it's a slow change over time. I think this is my last slide, Dr. Kramer. But so who's a candidate for cross-linking? So young patients, older patients. Thinness is not really an issue. There's a lot of confusion about the thickness of the cornea. It turns out that, because I was part of the FDA clinical trial, that we were actually able to treat very thin corneas. We actually then put drops during the procedure to make the corneas thicker for the treatment, and that's how thin corneas can be treated. So there's really no, in my opinion, no minimum thickness. I mean, I guess there must be some minimum thickness, but we can treat very thin corneas, which are typically more advanced, with cross-linking. And then again, we can thicken them up to certain levels and then do the treatment. We can treat very steep corneas because they can, even if they have crossing and we can stop them from getting worse, they can be fitted with a scleral contact lens. Corneal opacities, even if they're in visual axis, but they're not covering the whole vision and they can see with a contact lens, a scleral lens, they can be a good candidate. And then patients with previous surgeries like corneal transplants, lasik, smile, TRK, or ring segments can all have cross-linking. So it's a pretty wide group. So anybody with keratoconus, they really can benefit. And with that, I'm going to turn it over to Dr. Kramer to really share with us pearls of scleral lenses, which are just game-changing.
And what you see up there is actually a very interesting looking scleral lens, but it's actually showing just all the customizations that we can do today. And this scleral lens that you see in this photo was actually custom designed for the unique shape of the patient's eye, which is something that we can do. And of course, we do this in order to make a lens very comfortable, stable, and obviously be able to improve the vision of our patients. So I'm just going to go through a few cases. This is the OCT of a 36-year-old female with advanced keratoconus. She also has intacts. You can see the intacts on the OCT are represented by empty holes. And you can see the steep area of the cornea there. And then, of course, you can see the scleral lens and the tear film reservoir on top. And what's really interesting in this case is that the visual acuity without correction is 2300, and with the scleral lens is 20/20. So this is just showing, you know, the visual improvement that we can give to a patient with even advanced keratoconus.
Yeah, this is an amazing case, and it makes me so happy when our patients that have severe keratoconus can be, you know, be fit by someone like yourself, Dr. Kramer, and just changes their lives. So it's just amazing what you do.
Thank you. And I think that, you know, patients get really excited about the visual improvement that they can get with cross-linking as well. And I think, again, I've said it several times already during this presentation, but I really do believe that the combination of cross-linking and scleral lenses is really key for success in someone with keratoconus. So here's another patient, and actually no, this is the same patient. So you can see this 36-year-old female with advanced keratoconus. Again, the intact segment, steep area of the cornea, scleral lens, tear film reservoir, showing a very nicely fitting scleral lens, and again, visual acuity 20/20. So a successful and happy patient. Yeah, you can go to the next one. And here you can see this 53-year-old male with advanced keratoconus and intacts and the scleral lens on top. That green area you see is fluorescein that we put into the scleral lens with saline prior to applying the scleral lens, just so we can see the fit. And again, we can see those intacts in this patient. And in this patient, the visual acuity with glasses is 20/40 and with scleral lenses 20/25. So, and a lot of the time, you know, if they're seeing with glasses, they're seeing ghosting, they're seeing halos, which we can really eliminate with scleral lenses. And as Dr. Trattler mentioned, we try to avoid corneal transplants because that's kind of like our last resource, or our last resort in patients who have keratoconus. But in these patients, we do fit scleral lenses a lot, and you can see in this case that just the edge of our scleral lens there, and our lens fitting over a patient with a corneal transplant whose vision without glasses is 2200 and with a scleral lens is 2020. So again, giving this patient the visual acuity that they want with the scleral lens. And of course, what we're trying to do here is you can see the edge of that lens, how it lands on the vessels on the conjunctiva overlying the sclera. You can see that we're not compressing any blood vessels, and that it's just landing very gently on the ocular surface. And this is something that we customize in order to allow patients to be able to wear their scleral lenses all day and comfortably with good vision. So you can see this patient also had a transplant, and this patient had keratoconus after LASIK. And you can see that this patient had 2400 without correction, and with their scleral lens 2015. So it's really, really amazing the visual acuity that we can achieve with scleral lenses. Again, I want to emphasize that we cannot stop progression with scleral lenses. So it's not enough just to have keratoconus and get scleral lenses. You can fit the best scleral lens in the world, but it won't stop the condition from progressing. So I really do think that cross-linking is something essential for people with keratoconus as well. So again, scleral lenses can provide outstanding vision to patients with advanced keratoconus, and repeated again that cross-linking stops progression, scleral lenses do not, and cross-linking also can improve corneal shape and vision over time. But the scleral lens is what's going to give them that 2020, 2015 vision. And what's really interesting, and we've shown this in several studies, is that scleral lenses can actually reduce the need for corneal transplants in severe keratoconus. So this is one of my favorite studies. It's by a good friend. Yeah, you can go to the next one. It's Dr. Kopin and colleagues did this study. They tested several different 51 eyes actually, and 40 of the 51 eyes with severe keratoconus that would have otherwise undergone transplant surgery were successfully treated with long-term scleral lens wear, and they followed these patients for a long time. And so what this means is that they were actually able to delay or completely avoid doing surgery in these patients just by fitting them in scleral lenses, which I think is amazing. And I'm sure, Dr. Trattler, you've seen in your practice that since we've started fitting scleral lenses that you've had to do less corneal transplants, right?
Oh man, it's been amazing. You know, I'm much older than you, Dr. Kramer, so I've been in practice for over 20 years. So when I first got into Miami, I had these patients that had keratoconus and other conditions where our natural sense was to do a transplant. And I did a lot of transplants in my fellowship in Texas. And then I met Dr. Boschnick, who I know you know as well, and he was able to taught me, like, you know, how about scleral lenses and how these patients didn't need transplants. And it was unbelievable, game changing. This is like, you know, 15, 20 years ago. And that was just the beginning stages of scleral lenses. I mean, I know what the technology you're working with now is so much more advanced than what was available 15, 20 years ago. But it's just, I actually ended up stopping performing corneal transplants because the volume had dropped so precipitously once scleral lenses became available. It's just a rare situation to need a transplant in my practice.
That's so interesting. And obviously we want to try to avoid doing corneal transplants when we can.
Yes. So this is our summary. I can go back and forth. So first of all, the underlying genetic cause of keratoconus is multifactorial, which we hope we shared with you in that earlier part of the talk. There's so much more to learn, but it's definitely very promising. And the new genetic test is quite promising. And as Dr. Kramer pointed out, I shared too, crosslinking can prevent progression and often improve corneal shape and vision. And Dr. Kramer?
Yeah, and I think that again, the genetic testing that we're talking about is new, and there's still more work to do on it. But I think it's a great tool to have and to add in order to determine, how closely you're going to observe someone who has keratoconus or who may develop keratoconus. Sorry, and also again, cross-linking scleral lenses is such a wonderful combination to treat people with keratoconus. I think there's a lot of future in genetic testing, and I really look forward to more developments and more studies in this area.
Absolutely. I agree. So Jason, we're ready for more questions.
Wonderful, thank you. Okay, yeah, we did get a couple more. We have keratoconus being a relatively challenging optical problem, inducing both lower and higher order aberrations. We have one individual kind of writing in, noting that they have ghosting with scleral lenses and that they actually prefer their vision with glasses. And their practitioner is kind of at a loss to understand kind of that, kind of a little bit about why that might be the case. Is it still common for you to find some of these challenging cases where you have some of the optical challenges remain difficult even with scleral lenses?
I think one of the main things I've found in my patients is that if they've been wearing glasses for years, it's not always the easiest to switch them over to something else. And that's just because the brain kind of gets used to seeing, what they're seeing in a certain way, and to just jump to a different type of vision that maybe gives them more acuity on the chart, but gives them ghosting in another direction, or ghosting that their brain is not used to, might be a challenge at first. I tell all my patients that they should try to wear their lenses for at least 7 to 10 days straight before making any conclusions. And I do think that's because there is a certain amount of adaptation that you need in order to kind of get used to the new vision provided. It may be that at the end of the day they prefer their glasses, and that's fine. Ultimately, it's the patient's decision, and I don't believe that one is necessarily better than the other. I've obviously get better visual acuity with scleral lenses in my patients. If a patient's happier with glasses, then why not? Do you know what I mean? So it really depends on how the patient feels and how they're seeing.
Sure. We had a couple questions come in about if you could comment on the frequency of visits. What are you recommending to your patients about how often they should go see their doctor, or if an individual has a child with keratoconus, or if an individual with keratoconus has a child, how often are you recommending those children be going to see the eye care professional?
I mean, that's a very difficult question because there's such a difference between, how the patients are. So let's just do the basics. The first thing is to get a comprehensive exam, understand whether the patient has keratoconus or they do not have keratoconus. So that will determine whether they need to be followed, their frequency. If they don't have it, then maybe it's just once a year. But if they have some suggestion or signs, maybe we'll see them back in 3 to 6 months. If they have keratoconus for sure, then you're going to start talking about cross-linking at an early stage. And then once they've had cross-linking, typically I see patients 6 months after the procedure, then once a year after, to follow them along to make sure they're moving the right direction. But they can always come in sooner if they detect changes in a negative way in the vision, they can come in sooner.
Yeah, and if they're wearing scleral lenses, of course, at the beginning during the fitting period is when we're going to be seeing them a lot of the time. And then after that, it depends if they're a new wearer or if they're already experienced wearer, we might see them less often. So it's really case by case.
Sure, that makes sense. We had a question regarding cross-linking and whether there's any data on having that procedure more than once in the same eye, or if that's a recommendation, or what you think of that.
So as I mentioned, in my experience, we have a 99% success rate that patients need just one treatment. That means 1% of my patients I've treated over the last 12 and a half years have needed a second treatment. And I've had 2 patients over that same period of time, over many thousands of eyes, and I needed a third treatment. In general, when I do the second treatment, we see a significant reshaping of the cornea and significant improvements. And I do wonder at times whether there might be a day when we're going to recommend a series of treatments where it's going to be one treatment and then 6 months later you do the second one. And that might happen when Epi-on gets approved, that with the first treatment you're going to get, you lock down the cornea so it doesn't get worse and you get some improvement. In the second treatment, you get even more reshaping of the cornea. But right now the standard is just to do one treatment unless there's signs of slow progression over time. In my experience, I've seen no issues performing second treatments. They work very, very nicely, no complications, no issues.
Okay. Maybe two more. Is like when kind of circling back to the very beginning when you were talking about refractive surgery, it really does seem like, you know, a very comprehensive screening prior to any like refractive surgery is, given the increased prevalence, is going to be even maybe more important now if the disease is thought to be more common. Would you agree with that, or?
Yes, well, you know, the technology for screening patients prior to refractive surgery has improved over the last 20 years because we have newer modalities for measuring eyes, especially what we call tomography, which is a technology that's, the brand name is Pentacam or Galilei. These are the two main ones. They're able to look at the entire cornea and identify even earlier signs of keratoconus. That's really helped us identify patients at risk and avoid LASIK in patients that have even subtle levels of keratoconus. But doctors have been screening for keratoconus for years. You know, every patient gets screened, but it's just our screening technology has gotten better over time.
Okay. We had a question just kind of thinking a little bit about, and this may, Dr. Kramer, be one kind of that links up with something you said earlier about, you know, these things are very personal, like individual. How do you ever have recommendations for individuals about tasks that they perform, or whether they should or shouldn't do certain tasks if they have keratoconus? Like, do you ever talk to patients about that, or has that not been something that you talk about with them?
The only thing I really just recommend not to do is eye rubbing. I know you're talking about like maybe different activities that they can't do,
Yes.
but the only activity that I really don't think patients with keratoconus should do is rub their eyes. I really don't think there's a lot of, I think they have the freedom to do most of everything that other people do. I don't know if Dr. Trattler has different opinion.
Yeah, I mean, obviously, if they've had a transplant, that's a different story. But a patient with keratoconus without a transplant, they can act normally, just no eye rubbing. And when they're sleeping, the other thing that we see is sometimes patients will sleep with pressure on their eye, so they have to avoid that as well.
And obviously, if they're wearing scleral lenses, there may be certain things that they can't do, like sleep with their scleral lenses on, type of thing. But you know, there's not really many activities besides eye rubbing that keratoconus people can't do.
Okay. Maybe one last one, and you know, it's interesting. This is a question we've gotten almost every time I think we've had one of these webinars. I think there's a great interest from the kind of a community, specifically individuals with Down syndrome. Have you had any experience with individuals with Down syndrome who are dealing with keratoconus as well?
I can start. I mean, I've had the pleasure of taking care of dozens of patients, kids to adults with Down syndrome who also had keratoconus. We've successfully been able to cross-link every single patient. They've done very, very well, and I think they've all had a very good experience overall with the procedure. It's really made a difference for them by stopping their condition from getting worse and slowly making things better. So it's been very helpful. And so yes, it's definitely when patients with Down syndrome, they should be screened. They have a little higher risk of keratoconus, so they should be screened. If they have keratoconus, they can do very well with treatments.
And you know, I don't have that many patients with Down syndrome, but those that do have it and that have keratoconus can wear scleral lenses as well. It depending on the case, you know, they might need some additional help to apply and remove their lenses, but of course, again, it's case by case. But yeah, in general, they can wear scleral lenses and get cross-linking.
Well, we've come to the end of our hour. Did you have anything, kind of parting words or anything for the audience today?
I just want to say thank you for having us. It's been a true honor to be here with you tonight, and also to lecture alongside Dr. Trattler, who I have the pleasure of co-managing a lot of cases with, and who I look forward to continue working with.
Yes, I would say, well, first of all, Dr. Kramer, it's been wonderful working with you. You're obviously an amazing expert in scleral lenses and make such a difference for our patients. And second, I know Dr. Kramer and I both want to thank the National Keratoconus Foundation for putting on this series of webinars, and this one in particular. We're very honored to be part of that, and the organization is doing such a great job helping educate patients with keratoconus on how to understand their condition and understand that it's a major condition, a common condition. There's many other people out there that have the same condition. So thank you so much.
Yes, thank you.
Wonderful. Well, I'd like to thank Dr. Trattler and Kramer for your presentation this evening. And again, thank you to all of our attendees for joining us this evening, spending some of your night with us. Please be sure to join us for our November webinar in anticipation of World Keratoconus Day, which will be presented by Dr. Ed Bennett and Tommy Pham on the topic of Tommy's story. Please check the National Keratoconus website for the most up-to-date information on the webinar series. Until then, on behalf of the National Keratoconus Foundation, we wish you all the best. Good night.